Hello, good morning, everyone. So this is my second lecture. So basically, we are looking at the most important topic that with the involvement of other team members. So my name is Anas Hassan, and I'm one of the specialty trainee doctors in rehabilitation medicine in the UK. And I'm sharing some information and input that we learned all together. And this lecture will tell you a case scenario and the case history that we will look at through the journey from the amputation till the start of wearing the limb. So, and this will show you the importance of involving other multidisciplinary team in the care of the patient throughout this journey. So, how is the multidisciplinary team works and is basically when we need to introduce the MDT to the amputee rehabilitation because MDT in amputee rehabilitation consists of health and care staff from different organizations and profession working together to make treatment decisions. And an effective MDT uses the knowledge, skills, and the best practices from each person. So they are all collectively, they will be necessary in that one. So you need to involve them as that will help to the better outcome and better care. So the presentation aims to demonstrate the importance of this MDT in amputee rehabilitation and prosthetic care. And as we said, the effective MDT utilizes the knowledge, skills, best practices from different disciplines and different carers in the journey of any amputee. So let's talk about our patient's journey. So we have Mr. X, who had 2 years ago presented to the GP with a short distance claudication and small ulcer to his little toe. And that patient was referred to the vascular service. And this journey basically shows that the start of this patient all over by seeing a surgeon and also seen by a specialist vascular nurse practitioner, and then was referred to a vascular scientist who looked at the Doppler scan, which is basically looking at the vascularity of the limb itself, and been referred to vascular radiologist to confirm the vascularity of the limb itself. And so they went for an angioplasty, which is really important, and that helped to recover some of the blood flow and helped with the healing of the ulcer itself. And then was discharged from the service. A year later, returned with worsening symptoms, leading to an urgent referral and decision for transtibial amputation after MDT discussion. As you can see that after the year with and developed problems and complications, it's another referral to a vascular service. So the vascular surgeon seeing the patient said that this patient will need the amputation. And that all is not a collective decision by one surgeon or by one specialist, it's by an MDT. You can see that the decision to amputate requires an MDT. And that MDT involves rehabilitation physician, a prosthetist, and a physiotherapist and occupational therapist. So that decision shouldn't be taken easily because you need to see, and that will come later on, what level. Okay, so you can see that the patient, once we made the decision and the patient been decided to go for the operation for the transtibial amputation, there are multiple stages that needs to be seen before the surgery itself. So pre and post operative care. So if you look at how Mr. X received the pre-operative assessment and pain control, followed by the surgery involving a multidisciplinary team. This is basically to summarize what happened. And if we looked at the assessments that is needed in that one, it's really essential because the assessment before the operation will require some pain management. So the anesthetist on call came and done the popliteal block inserted, and that will help for a pain management, and that also reflect on the necessary of prevention of phantom limb pain on the long term. And this stage is really essential to prevent that complication. The patient was visited by the clinical lead occupational therapist for amputee rehab, and they made the environment visit, and they discussed everything about the next step for the prosthetic rehab process and the information provided. Measurement taken before the amputation, wheelchair provision, because they require wheelchair, they will not put the limb directly, and all the kind of questions that will come to their mind. The individual with going for the amputation will require to be assessed and answered, so to be given a reassurance. So if you can see, the patient will be cared by ward staff, including junior doctors, nurses, and healthcare assistants, while waiting for the surgery. This all before the surgery. Now, on the day of the theater, on the day of the surgery, so already been received the popliteal block, and to start with the pain control. Popliteal nerve, it's a nerve that located behind the knee, and that is really important to reduce the magnitude of the pain itself. And after that, the patient on the day of the surgery, they will be reviewed by the junior doctors, the nursing staff, and then will be collected by the theater porter, who will take the patient down, and then vascular consultant surgeon will review the patients, and the vascular doctor, registrar levels, the specialist, and then they will be seen by the anesthetist, assistants of the anesthetist, scrub nurse. Everyone will be taking care of that during the surgery. After the operation and the amputation, the patient will be returned to recovery room, and they will be still cared by the nursing staff, making sure that the pain is under control. Because what happened is that in the amputation, you cut through the bone, soft tissue, muscles, and the nerves and the vessels, all of these been injured, and there will be a catastrophic events on the local size, and that will need more management, better management. So now the patients now return to the ward, and now we started the following care. So will be reviewed and by the physicians and pain team, as well as referral to smoking cessation team, because that's really important to help them with stopping smoking. Rehabilitation commenced with the clinical lead occupational therapist and the specialist physiotherapist. Both will work together for amputee rehab, and they will be supported by the ward physio and OT team. So there will be a dedicated specialist, occupational therapist from the amputee side and the physiotherapy to support the ward care. This will help in the transition when the patient is going home. And you can see that after that stage, wheelchair will be provided by the occupational therapist. And they already made the measures. They make sure that environmental assessment been done at home to make sure that, hey, where are they living? And I understand that how is the situation is different from what happens in Gaza and what happens here. But these are the principles, and we try to take what we can do. So the wheelchair is needed, and is there any places for a wheelchair to be used? But we will come to that in a second. And then we will make sure that there are family to support with that, because patient will need to be patient will learn how to use the wheelchair by themselves and will need some support by their family. Now the patient will start already the daily rehabilitation from day one, and they will be seen by the physio, by the occupational therapist, and both they will start assessing the activities and see how the patient is able to do. Are they able to transfer themselves from bed to chair, and then if they are able from chair to bed, they can go to the toilet, and all of these kind of assessment to see how much of a strength they have, and that will help to identify the possibility if they are going for the prosthetic limb itself. And we will not forget about the pain management. Pain is continuous before, during, and after. That's really essential. If we look at day 5, what happens? The wound will be checked. Make sure that everything's fine. Vascular consultant already seen. Okay, and on day 5, once the wound is fine, we'll start the compression socking. Okay, so compression sock will be provided by the prosthetic therapy staff to start shaping of the residuum and manage edema. So it needs to shrink things. Now everything is swollen. The wound is okay. We will not putting the sock directly after surgery. We'll leave it for like 5 days. And then once the consultants are happy with the wound, there is no wound adhesions or anything, we'll just put the socking there. So compression sock is really important to reduce the edema and make the residuum not redundant or loose. Environment assessment will go in. They will go meet with the family. They will check about the patient's mobility at home, to going upstairs, downstairs, if there are any stair, and so on. Ongoing ward rehab with the OT and Visio, because already they provided the specialist amputees, and that will be taken to the next level. And then on day 8, while the patient waits in the inpatient, prosthetic rehabilitation already commenced in the specialist rehabilitation mobility center. So they will be taken to the dedicated place or the clinic to start having the mobility there with the prosthetic physiotherapy team. Day 9, the patient was discharged home, arranged for integrated care community, which is basically the community team, which is similar to you guys, that the patient will come. So the patient will go to their place of living, and the Visio and the OT, they will come visit them and see how they can accommodate rehab support in their place of living. Okay. District nurse will come to check the wound, making sure that he's healthy and everything is fine. There are no problems with the medication, and the wound clips or the suture will be removed by day 14. Now, Mr. X continues to attend the specialist rehabilitation and mobility center. So they will have visits to the outpatient, to the specialist center to do the amputation, the rehab itself, and they will continue doing it at home. So both are necessary. You can't just wait for the rehab in the specialist center. You can do rehab in your own home. And is that really necessary as well as the specialist center? Yes, because the muscles need to be active, and you need to continue doing the same exercises everywhere. And there will be an appointed for a primary clinic. This is a primary clinic assessment that will be involved rehabilitation consultants, which is part of my specialty, looking at the patients. A trainee rehab doctor, a prosthetist, occupational therapist. It will be like an MDT, a mini MDT, as more focused on the patients and trying to tick all the boxes, making sure that we are not missing anything and we are not getting any complication. And then from this assessment referral and onward, orthotics and podiatrist needs to look at the other limb. So we are not missing the other limb. So we need to make sure, because if the patient has an injury or like a trauma or anything, we need to check the other limb. Is the other limb still healthy enough to make the patient mobile? Let's say if there is problems with their nails, with their toes, any ulcers in the foot, any changes, any previous wounds, these need to be taken care of. Now, one of the things is that the prosthetist will commence prosthetic provision, meaning that there will be multiple appointments with the physiotherapy, and the prosthetist will come to provide the limb that, like, what they call is momentary or like a transition prosthesis. But it's not available all the time, and most of the patients, they will be ready by that time, and they are ready to have their definitive prosthesis. Now, during what happened for Mr. X, during physiotherapy session, wound breaks down, and advice sought from the MDT. So we found the wound. Oh, there is a problem with the wound, so we need to do something. So we sought the advice from rehab consultant. The rehab consultant is looking at the patient holistically and trying to manage this wound with antibiotics, wound dressing, or is that wound needs to be looked at by one of the specialists. And then also, once the patient brought back their home, so they will be looked after by another district nurse or by a nurse or by a specialist that's who've been taking care of these wounds, and making sure that the PAMAID is basically the compression device that if can continue despite the wound. Okay, that will help to make sure the compression is continuous. Compression socks. Wound completely healed, as you can see. Even with all the therapists continuing, we didn't stop, so patient can continue with that. And then what happened that Mr. X remains on open access to the prosthetic MDT. So basically, it will be a regular reviews and full prosthetic MDTs. Every time will be changing every 3 and 9 months because the patient's condition change, and then you can see how things going on and moving forward. But if you can see on a different level, there will be repetition. And that's really necessary to make sure that we're not missing anything. And this is basically what we involve all of those in the care for the amputee. It's not just a one-person care. It's basically all of these guys and delegates and professionals that they can look at this aspect itself. And we usually look at one of the things. How is the importance of each rule from everyone there? And you can see that every rule within the MDT is crucial. It's really important. We can't, we, as an amputee, as any individual amputee will need each person, as a physio, an OT, as a doctor, nursing, environmental visits, each person, you can see how many of them they are coming, the anesthetist, all of them, to make sure that they will be fit enough to wear the limb. It's not related to the prosthesis. Manufacturing the limb itself, it's 1 out of 10 importance. The others are really important. So making sure that they will be fit enough to wear the limb. And this is the aim. And